Okay, so looking at today's agenda, we are going to start with the technique chart. By the way, I'll mention this again, but the sacrum and the coccyx are peer checkoffs. So for me, next week, you're going to do C and L spine, and you're going to do sacrum and coccyx with a partner. I'd like you to get that done by week 5, but that's flexible. If something comes up, I'm flexible. So I have technique charts for you guys. We'll take a look at that just to kind of identify the positions that we're learning today. But we need to spend some time on the anatomy. And I know that many of you have started the recorded lectures, started reading your text, but the anatomy is a lot. And it's really helpful in understanding what you see in the x-rays if you have a better grasp on the anatomy. So we'll spend a little bit of time on anatomy. We're actually going to do some drawings. We'll look at the x-rays together. We'll talk about the Scotty dog. Maybe you've heard that term before. I'll show you the positions in lab, and then I've got some things to help you practice with what we've learned today. And then, of course, our checkoffs for C and L are next week. Any questions at all?
Yes.
Yes.
So we all have clinicals tomorrow morning. If it's 2 hours delayed, do we just come in then 2 hours late?
Yes. So you'd go to clinicals 10 to 12.
Okay.
For example.
Okay.
Yeah.
So that's what I thought too.
So no, actually tonight we have an extreme cold warning. So tonight is supposed to be like 40 below wind chills until 10 a.m. tomorrow morning. So tonight's supposed to be worse than this morning.
Do you know when we'll know?
So typically they try to cancel by 6 a.m. Usually it's before that because some nursing students have 6 a.m. clinicals. So I think they try to cancel early. But you should get texts or emails or calls if you're signed up. If your information is accurate in SIS, you should get they call it a rave push. Yeah. Okay. So I can't answer that as to when, but it should be early if they're going to do it. Okay. Okay. Other questions before we get started? Okay, you guys, here's the technique chart. And I am gonna, I have a copy for everybody, so let me hand this out for you quick. Here we go. Yes, you're gonna hold the head still and just open the mouth. Yep. All right, so, oh, go ahead. No. Okay, so here is your technique chart. So I tried to put these in order this week of the order that I will be demonstrating. So notice I'm starting with the lateral C-spine and then swimmers, then AP, etc. Also, notice all the projections this week are portrait. So when I say 10 by 12, that's referring to your dimensions, your light field. It should be 10 by 12 in size, but your orientation should be portrait. So your dials will say 12 by 10. Okay. I don't know if Stacy or Jeremy has shared this with you, but like typically when a radiographer speaks about the image receptor or the collimation size, we typically say the smaller number first, 10 by 12. Yeah, bless you. But, and I've mentioned this, students are always saying to me, well, what are the dials supposed to say? What are the dials supposed to say if it's landscape or if it's portrait? Look at your light field. You guys, you should know by now, I hope, what portrait looks like versus what landscape looks like. So who cares what number comes first on the dials? Look at your light field. That's what I want you to work on this semester. So this should say 12 by 10 in a portrait orientation, but again, we speak with the smaller number first. So that's why it's written that way. Also, notice WB stands for Walbucky. So C-spine we're going to do at Walbucky, And then L-spine and sacrum, we're going to move over to the table bucky, TB for table bucky. So we will talk about the different SIDS that we use. We'll talk about where you center. We'll talk about our tube angles in more detail when we look at the images. It is a lot. I agree with you, but I promise it'll be okay. We'll get through it. Do you have any questions about the technique chart? Okay. All right, going back to our agenda. Remember, sacrum and coccyx are peer checkoffs. I'll remind you of that again. And I'll share the competency forms with you so that you have those. I just haven't done that yet. The next thing I'd like to do is draw a vertebrae. So everybody should have some paper on your table. And I'm going to use color. I just think I like using color. So you want to grab some colors. Okay. All right. So I am going to, just so you guys know what I'm doing, I'm going to draw one vertebrae on the top half. And I know this is blurry, just give it a second. Your screen sharing is paused. Oh, I need to share my screen with the people at home. There we go. Okay, I'm going to draw, I'm going to split my paper into two. So I'm going to do two different drawings, just so you guys kind of know for planning purposes. All right, so I'm going to draw a vertebrae and then I'll explain what I'm doing here. Okay. I wish I was. I wish I could draw and I wish I could sing. Wouldn't that be fun? Yeah.
I know I can dance, but at least there's that.
Oh, I don't even know if I have that either. Good for you though, Kate.
I know I can dance.
Yeah,
So
I don't know.
I think I'd rather have that more than singing, because then weddings and all that stuff are fun.
Right, you can, yeah.
Whereas for some people, fun. Anyways, okay.
All right. So I have drawn a typical vertebrae, and there are differences in cervical, thoracic, and lumbar. But today I want to talk about the makeup of a typical vertebrae. And we are looking from the top down, okay? So this is going to be the right side. This is going to be the left side, posterior and anterior. And we're going to label the typical parts. So first things first, this big round anterior structure is our vertebral body. Coming posteriorly from the vertebral body is this semicircle called the vertebral arch. So let me label that over here. The vertebral arch. The vertebral arch is made up of a variety of structures, and we're going to label those next. But I want you to just recognize that this arch of anatomy or this arch of bone is attached directly to the body. The first part of the vertebral arch that I need you to know is this chunk of bone right here. and right here. That is your pedicle. The pedicle is the only part of the vertebral arch that articulates directly with the body. So let me say that again, just because I want to be clear. The pedicle is the only part of the vertebral arch that directly articulates with the vertebral body. Okay, so this chunk of bone here is pedicle. Okay. Next, you have these two things sticking out on the sides. Those are your transverse processes. Transverse process. And of course, you've got a right transverse process and a left transverse process. So it would be inaccurate to say the transverse process articulates with the vertebral body. That is incorrect. It does not. The pedicle's in the way. Okay. Notice we have these little bumps. We're going to come back to those later. The segment of bone in between the transverse process and this guy, so right in here, this is the region of the lamina. And again, you have one on your right and one on your left. Now, I am not a good drawer, as we just discussed, so, you know, the diagrams from your textbook are better, but just bear with me. And then this big guy right here is our spinous process. So again, in between your transverse process and your spinous process is that chunk of bone known as the lamina. In between your transverse process and your body is the pedicle. Okay. Let's see here. This circle right here, I want to label that. That is your vertebral foramen. Vertebral foramen. And can you guys tell me what passes through the vertebral? Yes, the spinal cord. Very good. So that is the hole for the spinal cord. All right. So far, I don't think this is too bad. We've got a body. We've got a vertebral arch. On the vertebral arch, we've got pedicle, transverse process, lamina, spinous process. Not too bad. We're going to come back to these bumps in a minute. Any questions at all? Okay, great. So now what I'd like to do is I'm going to draw a vertebrae from the side, a lateral. All right. Let me see if I can do this. Okay. Not too bad. Anterior, posterior, superior, and inferior. Okay, good. All right, I'm just going to grab a few more colors here. When everybody's ready, then we'll start labeling.
Skull, because I heard that for the, you know, when you like solving for the skull.
Yes, so great question. Let's talk about the skull. So every year I ask students to buy a skull. It is $30. So we have been for years trying to cut costs for students because life is so expensive. Groceries, gas, rent, tuition, books. So this year we bought 8 skulls, and so there's enough for each lab group. And we label them here in our class, and then next year Stacy typically paints them. So I'm not really sure what she's going to do, next year for you guys. But we bought skulls to keep here in lab to save you guys the $30. Yeah. If you want to buy your own skull, I'll give you a great link from Amazon that you can order one. We just felt like we wanted to save you some expense. Yeah. All right. So let's label the parts that we already know. Okay. This guy right here is our body, the vertebral body. And I made the body pretty thick and chunky. Each like cervical bodies are going to be smaller than this, but this is, again, just the typical vertebrae. By the way, on top of and below the body, I just want to draw these in. This is the region of the intervertebral disc spaces. That marker. So let me just label that for you. Intervertebral discs. Just to kind of orientate yourself there. Okay. Behind the body, we know is that vertebral arch. And so we have to label the parts on the vertebral arch. The first one right here is the region of the pedicle. So I'm going to label that out here, pedicle. So remember, the pedicle is the only part of the vertebral arch that directly articulates with the body. Okay. This is a really bad drawing of this, but this bump right here is meant to represent your transverse process from the side. If you look at your vertebrae from the side, the transverse processes are there. I'm just not a skilled enough drawer to draw them well. So that's what that bump is supposed to represent. Let's do green. This, the region of the lamina, then we know is in between the transverse process and the spinous process. So I'm going to just put it right about there. The region of the lamina. And then I'm going to label spinous process here. Okay.
So this says transverse process, is it pointing that little bump or this like whole thing?
It's this whole thing
Okay.
right here.
Yeah.
Okay, so those are the parts that we identified on our superior drawing. So we've got body, pedicle, transverse process, lamina, and spinous process. Not too bad. There's a couple other structures here, though, that you probably have noticed that weren't super visible on this perspective. So let's label those. So the first one, you see this big bump right here. So that is called your superior articular process. And that's this whole structure right here. Superior articular process. Okay, well, if this is our superior articular process, this point down here must be our inferior articular process.
All the way to the point.
Yeah, it's this whole structure. Okay, we're going to come back to those in a second. Do you see these half circle, half semicircles right here and right here? So this one is the roof of the pedicle. This one is the floor of the pedicle. Those have a name as well. So that is your superior vertebral notch and your inferior vertebral notch. So this semicircle right here is your superior vertebral notch. This semicircle here is your inferior vertebral notch. And we're going to talk more about those in a minute as well. Okay, so these are all of the key parts of a typical vertebrae. It's a lot, but it's not too bad when you draw it and kind of break it down into chunks. There's one thing that I kind of forgot to label, or I want to label now, I guess. On the surfaces of these superior and inferior articular processes, there's these little pads. And those pads have a name. Those are called facets. Facet. A facet simply means a surface where two bones articulate. And I talked about this, I think, last semester. It's almost like the pad on your glasses where they rest on your nose. That's very similar concept. It's just a surface on a bone where things articulate. And I just want you to know that the superior articular process and the inferior articular process have facets. Okay. How we doing? Yeah, okay. It is a surface on a bone where two structures articulate, or where two bones articulate. Like we have facets where your rib attaches to your vertebral body. That'd be another example of a facet we see in the spine. So I just kind of alluded to our next step. If these surfaces have facets, these surfaces must articulate with another bone. And that's what we need to talk about next. So let me zoom out for a second. So we've done really good here. We've labeled the key parts of a typical vertebrae. What I want to do next, I want to add a layer of complexity. I want to stack two vertebrae together. And I want to talk about joints and foramina. So over here, I'm just going to draw two vertebrae a little bit smaller from a lateral perspective. So let me see here. I didn't save much room. I apologize. There's one vertebrae, and then I'm going to draw another vertebrae. right below it. And then maybe just for good measure, I'm going to draw a third. I should probably quit while I'm ahead because I'm such a bad drawer, but
I'm sure you have the music video. How many times have you watched it?
It's gonna be all I know, I feel like it's
okay. So here I've taken a vertebrae from the lateral perspective, and I've just stacked it on top of another. So here's a set of 3 vertebrae from a lateral perspective. I just want to orientate you to some joints and some foramina. So of course, these are my vertebral bodies, okay, body here. These are my spinous processes. So can you guys see where the inferior articular process of one vertebrae meets the superior articular process of the vertebrae below? That space is called a zygapophyseal joint. Zygapophyseal joint. Let me zoom that. Yeah, so I didn't draw the facets, but yes, the facets are there. So again, I'm just going to say it again. Where the inferior articular process of one vertebrae meets the superior articular process of the vertebrae below, that makes a zygapophyseal joint, or a Z joint, we call them for short, because zygapophyseal is a mouthful. Okay, all right, good. Now, did you guys happen to notice the inferior vertebral notch of one vertebrae lines up with the superior vertebral notch of the vertebrae below, and that actually makes a big hole. Well, that hole has a fancy name. That is our intervertebral foramina. Intervertebral foramina. Now, remember, we are only looking at one side of the vertebral column. We have all of these structures on the other side as well. So if we imagine we're looking at the right side of the spine, let's just say, we have Z joints and foramina on the right, and we have Z joints and foramina on the left. We just can't see them here because they're superimposed with the right side. Okay. Yeah, I'm sorry. Yes. And actually, I'm going to show you a slide in a second where I have the written definitions for you. Yeah. Okay. So you guys, I really felt like it was important to draw this and identify these parts before we try to pick them out on X-ray, because that's our next step. We need to be able to identify these on X-ray. So any questions here before I switch screens? All right, so I am going to minimize this. I'm gonna start my video. Oh, I bet you I need to close. Oh, there we are. Okay. Back that up, holy moly. There, okay. And then I need to reshare my screen. And I'm gonna share this guy. Okay, so real quickly, let me just figure out why my video isn't working. I think I need to close this guy. That's why. And then turn that back on. There we go. Okay. Okay, so we drew a vertebrae. We labeled all the key parts. Next, I need you to be able to identify what is an intervertebral foramina and what is a Z joint in writing. And I've provided that for you here. So an intervertebral foramina, and foramina, remember, means hole. An intervertebral foramina occurs when the inferior vertebral notch of one vertebrae meets the superior vertebral notch of the vertebrae below. And as we talked about, there's a vertebral foramina on each side. Foramina is singular, foramen is plural. The zygapophyseal joints occur when the inferior articular process of one vertebrae meets the superior articular process of the vertebrae below. And we have one Z joint on each side of the spine the whole way down, cervical all the way down to sacrum. Okay. So this, by the way, this agenda is posted in Canvas. So you can always come back and reference this slide if you need to. Does anyone else think it's really warm in here?
No.
Okay, I mean, I'm okay right now, but I feel like if I move anymore, I'm gonna start sweating. It's really warm in here. Yeah, and I get that. It's hard to regulate. I would like to leave the door open if possible today. All right.
At what temperature do they shut down the school?
Well, it was 50 below. There was a couple winters ago. I don't remember what year. It was 50 below for like 3 days.
I remember that.
Do you? Yeah, and school's canceled. Say that again?
Wasn't that when there was a name for it? That was
The
the
polar vortex.
Yes, that.
I forgot
I
that.
was trying to
Yeah.
remember, because I remember for a basketball game, we did like a theme for one of the games before one day.
Oh,
So everyone like dressed in their stuff here and wore like,
You guys still have the game?
it was like after, once we finally got back to school.
yeah.
But, and we had like actually snow that one. If I remember it, we actually had snow that one.
Yep.
So you could just like go outside and like.
I remember my roommate in the city, she was in vet school. And she was in her like last year of clinicals, and she's like, we never shut down the vet hospital, and they shut it down
Wow.
during that time. So
That's
she was,
terrible.
like so psyched.
So, I mean, my gut is kind of saying a 2-hour delay. What's the matter, Devin? Oh, you want, okay. I mean, I guess had you not asked me, we just talked about it, so now that's kind of weird. Yeah.
Am I the only one that doesn't like getting up early and going?
Yoga? Yeah. Or is I have tomorrow. I thought it was supposed to be cold today. I'm like, "Oh, I don't wanna go this morning. It's the whole.
I see. I didn't understand why you were so,
Yeah,
I didn't understand why you were so,
They might honestly, you open them.
excited to go to clinicals.
well, upset about today versus tomorrow. I didn't know. Yeah.
Am I the only one that's not like, oh my God, I gotta get to clinicals?
You know,
Depends on the day. It's like the day before went really good, and yeah.
yeah,
Then
Yeah.
the day
I was hit or
wasn't
miss
great.
about diagnosis. Some days I just,
yeah,
but I love it.
good. Where are you again? Okay, Renton.
Okay, actually, though, for the, so the email that we do on another tech, can you see that we submitted that?
Okay, so any questions about what is an intervertebral foramina or what is a Z joint? Okay, so we are building a very complex cake today. We are learning the ingredients. The next step in building this cake involves understanding in what position of the C-spine do I see the intervertebral foramina, and in what position of the C-spine do I see the Z joints. And it is different for cervical, thoracic, and lumbar spine. So the next thing we're going to do is we are going to identify together in what positions for each spinal level you see the foramina and the Z joints. So I have a chart for you that I'm going to hand out.
Right.
And we are gonna stop sharing just for a second. We're gonna stop my video. We're gonna go back to the hover cam because I want to draw this with you guys for the folks at home. Right, we're gonna do this. And then let me make sure I'm sharing. I need to talk myself through all these steps. There we go.
When you're ready for a nap.
Oh my gosh, I know. Just hang in there, Kate. It'll be okay.
Only been an hour.
Okay, so I'm gonna be just really upfront and honest with you. I call this the spine chart. This is really important. I would definitely put this on my study guide for the exam. This is gonna be your best friend. We're gonna spend a lot of time practicing with this. I think this is the simplest way to help understand these complex concepts. Okay, so we know what the foramina are. We know what the Z joints are. We just drew them and we identified them in writing. If you want to see the intervertebral foramina of the cervical spine, you are going to position the patient in a 45-degree oblique. Okay. We are going to do posterior obliques in lab.
Is this in a recumbent or,
We're going to do these standing.
okay,
Posterior obliques, that's what PO stands for. Posterior obliques show the side away from, oops, I spelled from wrong, from the image receptor. So in other words, an LPO is going to show me the right intervertebral foramina. An RPO is going to show me the left. Because remember, we have foramina on both sides of the spine. Okay. So if posterior obliques show the side away, anterior obliques show the side closest to the image receptor. I'm sorry that got so crowded. I didn't plan that very well. Sorry. I'd be happy to print more boxes if you want to redo this when we're done. Or you could type up your own boxes too. Okay, sure. Yeah, no problem. Not to this box. All right, so again, we're gonna do posterior obliques. So I'll show you those when we go into lab. If I want to see the Z joints of the cervical spine, I need to do a lateral. So a 90-degree lateral. But there's an exception to that. That is only true for C2 through C7. If I want to see the Z joints between C1 and C2, I'm going to do an AP open mouth or the odontoid. And we will look at that on X-ray. Okay, we are not learning thoracic spine for a couple weeks in lab, but let's just fill it in since we're here. If I want to see the intervertebral foramina of the T-spine, I'm going to do a 90-degree lateral. If I want to see the Z joints of the thoracic spine, I'm going to do a 70-degree oblique. And posterior obliques show side away from, oh my gosh, from IR. Keep spelling from wrong.
Will everybody else decide?
No. Unfortunately, that'd be way too easy, Callie. I'm joking, but no, there is.
You're not.
Yeah. Okay. By the way, when we check off on T-spine in a couple weeks, we will not be doing obliques, just so you know. But a posterior oblique, so an LPO would show me the right Z joint, for example. But don't worry about that right now. If I want to see the intervertebral foramina of the lumbar spine, I'm going to do a lateral. If I want to see the zygapophyseal joints of the lumbar spine, I'm going to do a 45-degree oblique. Posterior obliques show side closest to IR. Anterior obliques show side away from IR. So, for example, an RPO is going to show me the right Z joints, an LPO is going to show me the left Z joints. We're not going to do anterior obliques, so I'll just leave it at that, if that's okay with everybody. Yep, you got it. So because we're not going to check off on T-spine obliques, I just think these two are opposites. So C and L are opposites in what you see in your obliques. And that's how I keep it straight in my mind. Okay, so I will happily print some more copies of these if you want to clean yours up a little bit. Again, I personally would put this on my study guide, and we'll practice with this in lecture quite a bit because it's important concepts to know. So we have been sitting for an hour. Should we take a break, get up and stretch? Okay, let's come back in 5 or 10 minutes.
That's wild.
All righty then. So the next thing I want to do, you guys, is I want to look at the x-rays of the cervical and lumbar spine. Remember, this is recorded also in Canvas, so you can review it again at any time. But here we go. I'm going to dim the lights just a little bit. And I would like to start with the lateral C-spine. Now, again, I mentioned this earlier, but I'm going to try to go in the order that I'm going to demonstrate them for you in lab. We typically start with the lateral C-spine because in a trauma situation, this is going to show you any real obvious fractures. So we would do this with the patient recumbent. We'd do a cross table lateral. But also this projection requires 72 inches SID, which we'll talk about more in a second. So usually I'll start with this one and then move into 40 or 45 to finish the rest of the C-spine. So you're going to use 12 by 10 portrait collimation. Like I mentioned, we need 72 inches SID. Do you know why? Yes, because of the oid. Good. So look at, because of the shoulders, we have a ton of oid. Oid causes magnification. Good. So to compensate for the oid, we increase our SID, which reduces our magnification. Good. You're going to place your central ray at C4 and mid-coronal plane. So notice they're in a left lateral. So we're going to do all of our spines left lateral whenever possible. So C4 is right about that Adam's apple region. So that's a nice, easy trick. Also, if you are correctly collimated to 12 by 10, put the top of your light field at the top of the ear. That works every time. Yeah. Yep. That only works though if you're correctly collimated. So something to keep in mind. So light at the top of the ear and your central ray right at that Adam's apple, C4. You do want the patient over the center cell because we're going to use AEC here, but typically we're looking at 20 at 70, 20 at 75, right in that range. So how do you know you're correctly positioned? Well, as I mentioned, left lateral. By the way, hanging protocol is going to vary depending on which clinical site you go to. So Marshfield Clinic, this would be flipped because it would face to the left. Mayo, do you guys know how they hang spines at Mayo? I guess I don't.
I haven't seen one.
Okay.
Since I've been there.
So yeah, how this is hung is just how I've just pulled the image off the internet. It can be flipped depending on the radiologist preference. It's really important during this projection that the patient relaxes their shoulders, especially like guys with muscular shoulders or large body habituses. Big bulky shoulders are going to obscure the bottom of the C-spine. So you really want them to relax because we're trying to include all 7 cervical vertebrae here. So typically we ask our patients to hold sandbags around their wrists. Our textbook teaches that if they hold the sandbags in their hands, they tend to clench their shoulders up. But if they have them on their wrists, they really relax their shoulders. The exception would be post-op patients that have a weight restriction. So you always want to ask that first before you give them sandbags. Usually the sandbags are 5 pounds in each hand, but I've seen 10 pounds also. So just make sure they don't have any lifting or weight restrictions. So you're going to count for all 7 vertebrae. When I'm doing the lateral, I like to start at the top. So here's the base of the skull, of course. This is C1. So this is the posterior arch of C1. This is the anterior arch of C1. Remember, C1's kind of unique. It doesn't have a body or a spinous process. So C1, 2, 3, 4, 5, 6, 7. So here's C7, and we've gotten almost all of T1. Ideally, we want the top half of T1. So this is really, really nice. I can't stress it enough. If their shoulders are raised or big and bulky, you're not going to see C7, T1. So it's really helpful to relax those shoulders. In fact, I even tell my patients, okay, take a big breath in, blow it out, relax your shoulders, really talk them through that process and emphasize the importance of it.
What if you have like an Ed from 90 Day Fiance?
Yeah, it's tough.
See that?
So
You guys know what I'm talking about, right? Yeah.
no neck Ed?
Yes.
Yeah. I've never
Oh,
seen the show, but I'm
hold
familiar
on,
with the
let me get a
concept.
Picture for you.
So we're going to talk about what to do for a person like Ed in the next slide. Okay. So while you're pulling up that picture, so in addition to all 7 cervical vertebrae, what other anatomical structures are we seeing? Think back to our chart that we filled out together. The Z joints. So let me point those out. Do you see this diagonal black line right here?
Yes.
That is the Z joint between C2 and C3. Diagonal black lines back here. Those are your Z joints. Right here. Notice, here's the one between C7 and T1. Notice you don't have that diagonal black line between C1 and C2. That is because you have to do the AP open mouth to see the Z joints between C1 and C2. And we wrote that on our chart. So I'll show you that in a little bit. C2 through C7.
And there's no like compensating angling for like the natural curvature of the C-spine.
I love that you mentioned that, not in the lateral. There will be a tube angle in the AP to compensate for the curvature.
Okay.
We'll talk about that in a sec.
So, sorry, and in order to see C1, you said you have to do the odontoid?
So to see the Z joints, the zygapophyseal joints between C1 and C2, you're going to do the AP open mouth. Yep. And that we'll look at in a little bit.
Ooh, excuse me.
Okay. Good. Any questions on the lateral C-spine? So, you know, you want to make sure the patient's nice and straight. There's no motion. You can see all 7 vertebrae. Nice and pretty x-ray. Notice, like Kate mentioned, there is a curve in the C-spine. We're going to come back to that because that is important. So we'll come back to that in a second. All right, swimmers. So this is the position you do if you can't see C7T1 because of your patient's shoulders. You're going to do a swimmers. We do not do a swimmers with every C-spine. It's only as needed. So you're going to use 12 by 10 portrait collimation. You're going to keep that 72 inches SID because we have a ton of void. This time though, we're going to center lower. We're going to center at T1. So your crosshairs are really skimming the shoulder here. The point of the swimmers is to penetrate through that thick shoulder region. So you're going to use 100 mass at 77 kVp, approximately. You know, it's going to vary depending on equipment and patient, but you want them over the center cell because you're going to use AEC here. So how do you know you're correctly positioned? Well, look at the patient here. You are going to ask the patient to raise their left arm and drop their right arm. So you're separating those humeral heads, those shoulders, to penetrate through that region better. So the left side, left arm is up, right arm is down. You're going to keep a sandbag in that right hand to relax that right shoulder. And then you want to make sure you include C7T1. When you look at this x-ray, can you clearly pick out C7T1?
No.
Exactly. It can be really tricky. Your job as a technologist is to get a nice, clear picture, no motion, with adequate density. The radiologists spent 12 plus years in school. They will pick out C7T1. To give you some reference here, here's the base of the skull. So I know I have C1, C2, 3, 4, 5, 6, 7, and this is T1. But let me just put this into perspective. On the swimmers, you do not need C1 because you got that on the lateral. So if you clipped that, that'd be okay. Do you see lung apices here? If you have lung apices, you must have T1. T1's at the top of our thorax. So look at the clues. If you can't find C7T1, that's okay. Look at the other clues you have. Okay, lung apices, the base of the skull. Just make sure you have a nice picture with no motion and adequate density. The radiologist will do the rest. Oh, yeah, I've never thought about that. Yeah, I like to use my crosshairs here and just skim the shoulder, but based on, let's try that when we go into lab. Cause I don't want to say that if that's not true for every patient. It does look true for this guy. Well, I mean, in theory,
Yes, but it's so different.
yeah, I'm trying to think about that. You may, I mean, if someone is 6'7", are they gonna have a longer neck than someone who's 5'2"? I mean, we all have 7 vertebrae, but what does that look like? So yeah, I mean, it might be different. So Devin, let's put that to test when we go into lab. Okay. All right, good. Any other questions about the swimmers? All right. Next, let's do the APC spine. So you're gonna move in now to 45 inches SID because we don't have any oid here, so we don't need to compensate for magnification. We're gonna use 12 by 10 portrait. And again, we're gonna center in the middle of the C-spine. So approximately C4, this time mid-sagittal plane. We are going to do our standing. You could certainly do it recumbent though as well. Notice though, we need to add a 15-degree cephalic tube angle. So if we go back just real quickly to our lateral, I think the lateral, you can visualize why we need that tube angle better on the lateral. So notice the curvature. Is the cervical spine curvature primary or compensatory? It's compensatory. We are not born with it. It develops as we grow. Babies typically start holding their heads up about 6 weeks of age. So once they start getting strong enough to hold their heads up, that's when that curve develops. So it's a first compensatory curve. As a result of the curvature, can you see how the vertebral bodies point inferiorly? Well, if we used a straight tube angle, we would not be shooting parallel through the joint spaces. If you add 15 to 20 cephalic, oh, look at that. We go right through the joint spaces. Beautiful. So if we go back to our AP slide, I'll hear people say this sometimes. Well, we use a tube angle because we need to get under the mandible. No, 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 no. That's not why we use a tube angle. We use a tube angle because the vertebrae are inferiorly pointed because of our curvature. Okay. Correct. Yes. All right. So we want a 15 to 20 degree cephalic tube angle. It places the central ray parallel to those disc spaces, as we talked about. In the AP, you will only see C3 through C7. So I like to start at the bottom and count my way up because here is the first rib. So if this is the first rib, this has to be T1 because the first rib attaches to T1. So 7, 6, 5, 4, and here's 3. You will not see C1 and C2 nicely on this one. You have to do that open mouth, and we'll look at that in a few slides. Now, let's talk about the mandible for a second. Notice this lady down here. Her chin is, I don't want you to extend the neck. I don't want the chin pointing upward, but it shouldn't be down either. It should be nice and straight. If you look at this x-ray, see this mandible right here? It's covering the top half of C3. I think to be better here, we should have straightened that patient, lifted their chin just a little bit, okay? Would I have repeated this? Honestly, I might have, because it is covering half of C3. Otherwise, I like it. The patient is straight. There's no motion. It's good technique. We've included a right marker. It's a nice x-ray. I just wish the mandible were up a little bit. All right, good. Questions on the AP?
So you want it like parallel, like before, or like more?
Yeah, that's a great question. So I would say, I think having this part of your mandible parallel to the floor, that's good. I like that. Here's the problem. If I raise my chin too much, the base of the skull comes down, and then the base of the skull covers the vertebrae. So you have to be careful that you don't raise the chin too much, because then the base of the skull comes down. So the base of the skull here is right here. You can kind of see it, kind of lose it over here, but this is the base of the skull. All right, good. Now, since we have a 15-degree cephalic tube angle on, and since we have 45 inches SID, let's do obliques, and let's do posterior obliques. Because I didn't mention this earlier. If you do, remember this chart we filled out? Posterior obliques show the side away from the image receptor. You use a cephalic tube angle with posterior obliques. If you flip the patient over and do anterior obliques, what do you have to do to your tube angle? Yeah, it has to be caudal. So since we already have a cephalic tube angle, why would I spin my patient around, do an anterior oblique and a caudal tube angle? That's like 10 more steps. Why would we do that? I mean, I exaggerate. It's only 2 more steps, but still. So let's just do posterior obliques with that cephalic tube angle. You're going to still center at C4, okay? And you're going to kind of center like in the middle of the neck here. And I'll show you for this line. And I'll show you that when we go into lab. So you are going to, all you're doing, you're leaving everything the same. You're turning the patient into 45-degree obliques. So you're going to do an RPO and you're going to do an LPO. And we do both always for comparison. So even if their pain is right-sided, the doctors want to see what the left side looks like too. Like, what does the good side look like? Okay, so we are visualizing in a posterior oblique the intervertebral foramina of the side away from the image receptor. So in this case, this patient is in an LPO. We're seeing the right foramina. This patient in the X-ray is in an RPO. We're seeing the left foramina. You see these big holes here? Those are the foramina. What passes through the foramina?
Spinal cord.
No,
What?
not that foramina.
Oh.
You'd be in trouble. And nerves, yes, off the spinal cord. Thank you, Kate.
Okay.
So remember, you have these on both sides of your spine, right and left. So that's where nerves come off the spinal cord and blood vessels. Okay, so let me ask you this. Here's your foramina. Remember, it's made from the inferior notch of one meeting the superior notch of the one below. What is this chunk of bone called in the middle?
I want to say it's the pedicle.
Yes,
Okay.
yes, it's the pedicle. This chunk of bone is pedicle. Oh, you betcha. So like CBO, if any of you are at Chippewa Valley Orthopedics, their doctors like obliques. Some places you'll never do obliques, and that's just their doctor's preference. So it really kind of depends on where you are, if you'll see these or not. Yes. So that's a great question. I'm gonna have you do both sides for this, and then only one for lumbar. Okay. All right, good. So questions on the oblique C-spine. So I may ask you during your checkoffs, hey, Kate, what are you seeing in this position? So your patient's in an LPO of the C-spine. What are you visualizing?
The right intervertebral foramina.
Yes. So that's what I'd like you to know that by next week. I'm not going to take points off if you don't know, but it's good to know what you're visualizing. Let me ask you a question. How do you know if your image is good if you don't know what you're supposed to be seeing? Right? Like that's a key part of it. So knowing what you're supposed to be seeing in your x-rays helps you to critique it. I know it's a lot. All right, ready? Let's look at that odontoid. So this is the last image we're gonna do. So by the way, most places, their C-spine protocols are a lateral, an AP, and an odontoid. Swimmers if needed, obliques are extra. They're not part of a typical routine, just so everyone knows. Okay, I mentioned 12 by 10 collimation. Really, you're gonna collimate even smaller than that because look, we don't wanna get the orbits and we don't wanna get the thyroid. So collimate smaller, I'll show you that in lab. You're gonna use 45 inches SID. You're gonna shoot right through the open mouth and mid-sagittal plane. And how do you know you're correctly positioned? Well, when you go to position your patients, you are gonna feel the base of the skull. So you're gonna palpate the back of their head, okay? You're gonna draw an imaginary line from the base of the skull to the top teeth. That imaginary line should be parallel to the floor. Because what you're trying to do is you're trying to line up, here's the base of the skull. You're trying to line up the base of the skull with the top teeth so that you can see the dens. So here is your dens, part of C2. Here is C1. Here is your zygapophyseal joints. Remember, you only see those C1, C2 Z joints in this AP open mouth. So here's what happens. If your neck is extended too much, if your chin is raised too much, the base of the skull will come down and cover the dens. If your neck is flexed too much, so your chin is down, the teeth will cover the dens. So you're trying to get that like perfect medium where the base of the skull and the teeth are aligned. Now, I need you to spend some time with this x-ray and look at the labels. So this is C1, this is C2. Remember what makes up a Z joint. It's the inferior articular process of one vertebrae meeting the superior articular process of the vertebrae below. The Z joint is in the middle. I don't know about you guys, but when I look at this, I want to call this the superior surface, and I want to call this the inferior surface. Because it's like a sandwich. It's like two pieces of bread. One is superior and one is inferior. But it's the opposite. It's the inferior surface of C1 meeting the superior surface of C2. So spend some time with that. We'll practice in lecture 2. Now, one other thing before we move on. If your patient has any tilt, so tilt is a new concept we really haven't talked about much. This is tilt. This is rotation. So tilt or rotation can make those Z joints look asymmetrical. How does the radiologist know, because they're not in the room with us, right, when we take our pictures, how does the radiologist know it's not our positioning and they don't have a spinal cord injury? They don't. So you have to be super detail oriented so that your Z joints always look symmetrical. So watch for tilt, watch for rotation. We don't want to mimic an injury. Great question. I would try to position, you mean like if you couldn't undo the tilt or rotation?
That would be good.
Yeah, so you sure could. You sure could. I think the best way to answer that is most traumas are going right to CT. So we're not doing a lot of these for trauma, which is a good thing, honestly. CT is just a better modality for the spine. But yes, you could certainly get creative. I've never tried a tube angle with this projection. But yeah, if you had to compensate for tilt or rotation, you could sure try. Wow. Like a Fuchs or a Judd? Yeah, yeah. So the Fuchs and the Judd, we'll talk about those. Those are alternatives to the odontoid if you can't get it. That's too bad.
And the blue.
Um,
They're like, true.
was it a trauma or was it? So she was just having neck pain, like she wasn't in a car accident or, okay. So a lot of times, and then Kate will come back.
Mhm.
If the teeth are covering just the very tip of the dens and it's not a trauma, I usually will pass that because you could take 5 x-rays and still not get a perfect one. To your point, yeah.
So, I have TMJ. So mine, like
So you
naturally,
have problems with your TMJ, because
Yeah.
we all have TMJ.
okay. Problems with my TMJ.
Okay,
I guess for people who can't open up their mouth as wide, is that an issue if like people just can't open up that wide?
yeah, it can be for sure, because your teeth will obscure the dens.
Yes, and I don't have that small of teeth either, so, you know,
You don't have big teeth.
no, I love my teeth,
Yeah, okay. I thought you were implying that you had big teeth.
no,
Sorry. I took that a step farther than I needed to. didn't
yeah.
I? So, you could try the Fuchs or the Judd too,
Okay.
which we can talk about.
But we don't need to check off.
No, so let's not worry about those today.
Okay.
All right, good. Any questions about the AP open mouth? Do you need another break?
Yes.
Okay, let's pause.
Dr. you have a nice AM.
Thank you.
All right, if you need me to shut the door, just let me know. I'm just trying to prevent a sweat outbreak for me. Okay, let's transition to AP lumbar spine. So we are going to move to the table and do this recumbent. Many physicians want this standing though. They want to see how the spine bears the weight of the body. We're going to do ours on the table as though the patient maybe has an injury. So you are going to use 17 by 14 inch collimation. And you're going to collimate down to about 8 or 9 inches. So you're going to start with this, and then you're going to collimate inside to side, is what I'm saying. I never collimate top to bottom. I leave that open 17 inches all the time. All right, you're going to use 45 inches SID in our room. Remember, clinicals, you may be using 40. Your textbook teaches to center at iliac crest and mid-sagittal plane. Can you guys tell me what vertebral level corresponds to iliac crest?
Oh,
L4.
L4 and 5?
L4, L5. How many lumbar vertebrae do we have?
We have 5.
It's like a game or
Right,
yeah.
because you eat breakfast at 7, lunch at 12, and then dinner at 5.
That's awesome. Yes, that is
Yeah.
correct. So let me ask you this. If we need to include all 5 lumbar vertebrae, why are we centering towards the bottom? Why are we centering at L4, L5? Wouldn't it make more sense to center at L3 in the middle? I respectfully disagree with your textbook here. I like to center 2 fingers above crest, closer to L3. Here's why. You have to include the bottom half of T12. So notice there's a rib here. So this has got to be T12. All right. So if I center closer to L3, I know I'm going to get T12. Okay. So when I'm counting lumbar vertebrae, I start at the top where there's a rib, that's T12. So L1, 2, 3, 4, L5 right here. And then this is sacrum. That's it. It's kind of like a portrait KUB where you collimate in. It's pretty straightforward. The most challenging thing is if you can't find crest on your patient, which we know happens.
You can do where the elbow bends and where the crest is.
Yes.
I can do that on- Boy.
Yeah, yeah, that's a good trick.
Yeah, where the elbow bends. At the top of
So yeah, where your elbow is approximately at crest.
What a trick.
Yeah. Okay, so don't forget to include a marker. Make sure your patient's nice and straight. This is a really grainy x-ray. I apologize, but hopefully, you don't have any motion, adequate density, all of that jazz. All right, I put my marker in the bottom corner. Some people put it on the side, could go in the top corner, just so it's not in any of this anatomy, the transverse processes.
So it doesn't matter if it's in the pelvis, or the ilium?
No,
Okay.
I would say no. All right, good. Now let's look at oblique lumbar spines. Remember, we do oblique lumbar spines to visualize the zygapophyseal joints. Remember, obliques of the C-spine, it was to see the intervertebral foramina. Okay. So the patient's already recumbent. We're going to turn the patient into 45-degree obliques using a wedge or a sponge. We always do both obliques for comparison. This time, your text teaches to center at L3, so 2 fingers above crest, and 2 inches medial to the elevated ACIS. So you're going to find ACIS, and this line should be 2 inches medial. So I'll show you that when we go into lab, and I'll show you a trick I like to use too. All right, so you always do bilateral for comparison. Remember, an RPO is showing the right Z joints. It's the opposite of the cervical spine. The LPO is showing the left Z joints. When you check off next week, just show me one oblique. That's fine. Now, let's look at our X-ray and see if we can identify the Z joints. So, do you guys see these vertical black lines right here? That is a zygapophyseal joint. Have you heard the term Scotty dogs out at clinicals? Oh my gosh, really? Okay, so Courtney has. When you look at this spine, can you see? I'm going to trace it. Here's the ear, the nose, the front leg, the back leg, and the tail. Oopsie, can you see a Scottish Terrier in that spine?
Oh.
This is the eyeball of the Scottish Terrier right here. So a zygapophyseal joint occurs when the front leg of one dog meets the ear of the dog below it. Remember, it's the inferior articular processes of one meeting the superior articular processes of the one below. So I want to transition to a different slide just for a second. Unless you wanted to take a picture real quick, Madison. I didn't want to screw you up.
No,
Okay. I want to go back to our agenda slide. And I want to show you, this is the Scotty dog. Do you see that now? Yeah. So you got to take this and then superimpose it over the spine. That's what we're looking for.
So this isn't one vertebrae, this is like 2 vertebrae together.
No, this is one vertebrae. So this is a vertebrae obliqued to 45 degrees.
Okay.
The Z joint, now if I were to put another Scotty dog on top, the ear, where the ear meets the front leg, that's where the Z joints are, right here.
There was a vertical black.
Yes, and we'll go back and look at it again. I need you to know the parts of the Scotty dog, particularly the front half. I don't care about the back half of the Scotty dog. I need you to know that the ear is a superior articular process of that vertebrae. Remember, this is an oblique vertebrae. I need you to know that the nose of the Scotty dog is the transverse process of that vertebrae, one side of it. Because look at the other, oh, sorry, I was looking for the other transverse process, but we don't see it. The eye of the Scotty dog is the pedicle. The neck of the Scotty dog is lamina. Pars interarticularis, we'll talk more about that in lecture. Yep, so typically I put up x-rays and I have you trace one on an x-ray, and we'll do that next. Yeah. The front leg is the inferior articular process. So I need you to know the front half of the dog. So like on a test, if I were to give you this diagram, I'd need you to be able to label the parts of the front half of the dog. Okay.
Lamina and pedicle are really confusing, so it's nothing like
This whole thing is confusing. And
It's nothing like this.
I know, and here's what makes it more confusing. So let's go back. Okay. So this patient's in an RPO. Okay. Right side, right wing is flat. Which Z joints are we seeing in an RPO? We're seeing the right Z joints. If you were to look at your anatomic model on your table and put your patient in an RPO, from the top, like looking down at your patient, you cannot see the right Z joints. They are under the spine. That's, I think, what makes it incredibly challenging is you can't see it. It's underneath what you can visualize. Does that make sense? Kinda. So you are imaging the Z joints closest to the image receptor. If you were to position your spine that way, you wouldn't see them from the top down. Okay, so we're gonna pause here. Resume. So you guys did a terrific job picking out the Scotty dogs on our view boxes. If you take the X-ray and you can see the Scotty dogs, you know you got the Z joints. That's all. The Scotty dogs are just a visual trick for us as radiographers to know if we included Z joints or not. And I mean, they're there, but what if you over oblate your patient or under oblate your patient? Your Scotty dogs may look a little off. So the Scotty dog is just a radiographic clue that you're correctly positioned. Okay. Now, oh, I just lost my train of thought. Okay, so this black horizontal line or vertical line rather, that is our zygapophyseal joint. Oh, I know what I wanted to say. So can you see, like maybe on your x-rays up here, did you notice how like L1, L2, and maybe L5, they weren't as easy to see, but you could see them really good in the middle of the spine? I know most of you, it looks, so like when you look at this x-ray here, or even this one up here on the screen, can you see how the Scotty dog is less pronounced than maybe
Yes.
right here?
Yes, 1,000%.
Okay, there's a reason for that. That's what I wanted to talk about. L1, L2 are closer to thoracic vertebrae. And we know we need 70 degrees of obliquity to see thoracic Z joints. So like L1, L2, you might need to use 50 degrees of obliquity. It's the opposite down at the bottom. L5 is closer to the sacrum in terms of anatomy. Remember, a sacrum, we do 30 degrees of obliquity. So 45 is a good general survey, but if you wanted to see L1, L2 Z joints, use a little more, like 50. If you were looking at L5, S1 Z joints, use a little less than 45, maybe 30, 35. So that's what I wanted to point out. Questions on lumbar obliques? Are you guys comfortable identifying this as an RPO based on the wings of the pelvis? Yes, if it's hung correctly and marked correctly, yeah. Whatever wing is flat, that's the wing that's the side that's down. Okay, okay. I wanna get rid of this bar here. Okay. Lateral lumbar spine. Again, you can do this standing. We're gonna do ours on the table. 17 by 14 inch portrait collimation, 45 inches SID. Here again, your textbook teaches to center at crest and this time mid-coronal plane. I like to center closer to L3, so I'm right in the middle of the spine. So I like to center 2 fingers above crest. If you guys want to center at crest, that's fine. I'm just doing math and I think L3 is better than L4. Okay. Now you need significant more technique here, 40 at 81, because you're shooting through a pretty thick body part. So you're going to have a lot more scatter here as well, which is why I encourage that you use collimation. Notice this is collimated. We don't need the whole abdomen. You just need, you know, spine. So I would clip off the front of the abdomen to prevent excess scatter. So we're going to do ours recumbent. You could certainly do this standing.
Is the, you said underneath?
Yeah. Let's talk about that. So do you know why that foam thing is there?
Is it just for like support?
Yeah, support of what?
For comfort and so the kind of drop.
Yes, it's to prevent sagging of the spine. So I am a prime example. My hips are way wider than my waist. So when I lay on my left side, my spine could sag a little.
Which then would pinch the.
It's good. Your vertebrae are
the
going to look,
joint.
yeah, they're going to look rotated. Your vertebrae look rotated. So if you've got a patient with bigger hips than waist, putting that sponge under the waist helps support that spine. Good. Do you know what this black strip is right here?
Oh, is that the, oh, I think we learned it in Stacy's, right?
A lead
Yeah.
strip. Why is it there?
I can't remember.
Yeah, it is to prevent scatter from reaching the image receptor. But nowadays in digital imaging, we're not using these anymore because they could interfere with image processing. But in the olden days, we always used this to capture scatter before it gets to the image receptor. Okay, so when I'm doing a lateral, remember left laterals, you have to include all 5 lumbar vertebrae. I like to start at the bottom and count my way up. So here's sacrum. So 5, 4, 3, 2, 1. Beautiful. In addition to the 5 lumbar vertebrae, do you remember from our spine chart what other structures we're seeing? What are those called?
Intervertebral foramen.
Intervertebral foramina. Yes. So let me point those out. Right here, here's the foramina between these 2 vertebrae. Here's the foramina. Now, what passes through the foramina again?
Nerves and blood vessels.
Good.
Not your spinal cord.
Correct. Where does your spinal cord end, by the way?
Does it go, does it split? Or no.
L1. I got
What?
an L1 on the, oh.
So-
Your medulla oblongata.
No, that's in your brain.
That's where it starts, up in your brain. Yeah. Yes. So your spinal cord goes to about L1, L2,
Mhm.
L1, L2, and it the end is called the conus medullaris, and then it kind of splits into nerves. And
Mhm. Well, can I tell a really like funny yet embarrassing story?
do you want me to pause the recording?
Sure.
Okay, one sec.
Okay.
All right. So one little tidbit I want to add. If your patient, like, we got to check that their shoulders and their hips are nice and lateral, they're not like rotated at all. Because if you are rotated, or let's say they're rolled forward slightly, you're seeing the vertebrae from the side, right? If they're rotated at all, you'll see both sides of the vertebrae. The other side will poke through the, you'll kind of see it in the foramina there. So you really want to check for rotation. The other thing that I want to show you or point out is look at the spinous processes. Do you see how big and thick and chunky they are? Okay, but look at a T-spine spinous process. That's always going to be another clue too. Like if you don't know where you are in the spinal column, if you don't have any clues, if you can't tell, look at the spinous processes. The big, thick, chunky ones are going to be lumbar. They're going to be smaller and skinnier as you go up the vertebral column. Okay, beautiful. Questions about the lateral? All right, there's one more that we need to talk about for lumbar, and then we're going to talk about sacrum and coccyx, and then we'll be done. Now, can you imagine if this patient had large body habitus, really wide hips? Sometimes it is very difficult to see L5S1. So here's iliac crest right here. Okay, so you can see it truly is at L4, L5. If the patient's got really big hips, it can be difficult to see this joint space. That's when we would do the spot. Let me move this. Well, no, because some facilities do a spot with every lumbar spine. Some facilities will only do a spot if they can't see it on the lateral. So it kind of depends on your clinical site. Marshfield Clinic, correct me if I'm wrong, I feel like they only do a spot if they can't see it on the lateral. Does anyone know? Sure. Okay, well, in any case, we're gonna learn how to do it if you need to do it. The L5-S1 spot shows us L5, the joint space, and the top of the sacrum. Again, many clinical sites, if you can see it nicely on the lateral, they won't do this additional projection. It's a lot of dose for your patient. I mean, 50 at 85 is not insignificant. So you're going to use 12x10 portrait collimation, 45 inches SID. You are going to center 1.5 inches below crest and 2 inches behind ACES. Now, personally, that's a lot for my brain to remember. When I'm talking to my patient, I'm getting a history, I'm worried about what I'm going to eat for lunch. So I'm going to show you a trick. I have another W trick that I'm going to show you when we go into lab. If the W trick doesn't work for you, then please remember 1.5 inches below crest and 2 inches behind ACES. Okay. So that's a great question.
Like really close.
Yeah. Yeah.
And crest, 1.5 inches below it is like pretty much ACES.
Oh, okay.
Yeah. Yeah, that's true. So you could just use ACES. Yeah. Okay. Thank you. Okay. One other thing, we got to add a 5 to 10 degree caudal tube angle. So notice adding that tube angle is going to match the interiliac line, the line between both iliac crest. So the goal is to help open up that joint space and make it visible. If your joint space isn't open, it could be that patient just has a very narrow joint space, or it could be you need to adjust your tube angle. Have you guys seen this projection done?
Yes.
Okay. So some people are still doing it if needed. Okay. Yeah. Okay. All right. Yeah. Yep. Yeah. You may not need, you could calm it down from 12x10. Gianna, did you have a question? No?
No.
Okay. All right. So I'll show you how to do this. You're going to want to use a left marker since they're in a left lateral. Do you guys notice the marker is anterior? If you put the marker posterior when you're doing a spine, you run the risk of being in the spine. So always mark anterior or on the table. And I'll show you that when we go into lab. All right. This ends our checkoffs right here. The next 3 pictures are peer checkoffs. Yeah, I know. All right. Lateral sacrum and coccyx. So if you get an order for a sacrum coccyx, it's going to be 3 pictures. In the lateral, you're going to get all of sacrum and coccyx, and then we're going to do 2 APs, AP sacrum, AP coccyx. So it's 3 pictures. In the lateral, you're going to use 12x10 portrait, 45 inches SID. You are centering 3 to 4 inches behind and 2 inches below ACES. Again, I will show you a trick because that's a lot for my brain to remember. So I'll show you a trick I use. Otherwise, that is where you can put your central ray. Again, significant high dose here, 50 at 90. And not that it's a high dose, but it's a lot. And there's going to be a lot of scatter because this is a really thick body part. So you want to make sure your patient's still in that left lateral position, and you need to include the entire sacrum and coccyx. Pretty straightforward. You know, if you can get your centering down where you're supposed to center, this is a nice, easy x-ray. Do you guys notice while we're waiting, do you notice how the sacrum is curved this way and the coccyx is curved this way? So posterior to anterior curvature. That's why we add a tube angle for our APs. We're gonna look at that next. Any questions on the lateral? No tube angle here. All right, AP sacrum. So 12 by 10 portrait collimation, 45 inches SID. You are centering 2 inches above pubic symphysis. So in the positioning videos, I say that's close to ACES. It should be a little below ACES, truthfully, but we'll look at that when we go into lab. You need to add a 15-degree cephalic tube angle to compensate for the curvature of the sacrum. You want your central ray perpendicular. If I'm going to back up just a slide, just a sec, you want your central ray perpendicular to that sacrum. That is why we add that cephalic tube angle. So you need to include the entire sacrum. So let me show that to you. So here is the top of the sacrum. Here's that SI joint all the way down here. Beautiful. If the patient has a lot of gas or stool in their colon, that's going to obscure visualization of the sacrum. There's nothing you can do about that. So just, center well, no motion. So we're going to have them hold their breath to prevent motion. And have an adequate technique, and that's the best we can do. Yes. So if we go back a slide, it's to compensate for this curvature of the sacrum. So you want your central ray perpendicular to that bone.
I'm assuming that AP coccyx end is the other way.
Yes, it is. Good.
So almost every, for this whole thing is a 15-degree. Yes,
Tube angle.
yes,
The spot would be the exception. That's only 5 to 10.
5 to 10. And then for coccyx, it's,
Correct.
so let's just say 10 to 15 for almost everything.
All right. So AP coccyx. I remember that this is 10 degrees caudal because we have 10 toes down. If that doesn't make any sense to you, forget I said it, but that helps me keep my tube angles straight between my sacrum and my coccyx. Otherwise, everything's the same. Collimation, centering is even the same. 2 inches above pubic symphysis and mid-sagittal plane. The only difference here is you're throwing on a 10-degree caudal tube angle. So sacrum is 15 cephalic, coccyx is 10 caudal. Your job is to make sure you include the entire coccyx, and ideally it is not superimposed with the pubic symphysis. Hopefully those structures are separated. I was at clinicals last week with the second year, and the coccyx was over the pubic symphysis. They tried to adjust their tube angle. They just couldn't get it. So we ended up sending it. But ideally, those two structures are separated. Correct. Correct. You got it. Good. Okay. It's the same principle like why we use a tube angle for a foot, because you want your central ray perpendicular to those metatarsals. All right, good. So this concludes our film review. This is recorded. I'll put it in Canvas. I'll put this in Canvas as well. Do you have any questions at all before we go into lab? Okay. So I am going to end our recording. Well, I'm going to pause, resume recording. Okay. So history questions. Okay. So typically when you get an order for a spine, you're going to know the reason, pain, fall, motor vehicle accident, whatever. So let's ask the 3 W's. What happened? When did it happen? And where does it hurt? Previous surgeries are so important with the spine. Not only do radiologists want to know if they've had a previous fusion, laminectomy, etc. But also it may dictate whether or not we can use sandbags for the lateral C-spine. So previous surgeries are really important. And also, I want to introduce a new word to you. It's called radiculopathy.
Like, are you being ridiculous?
Yes, that is the question.
Really?
No.
Oh,
Radiculopathy refers to numbness and tingling in the extremities. So if you're imaging the lumbar spine, it's not uncommon for patients to have numbness and tingling in their legs. So you just want to indicate that. So for example, I could say left lower extremity, numbness and tingling times 3 months. 3 months, 3 months, no previous surgeries, no injuries. See how easy that is? That tells the radiologist a lot of information. Or I could say left lower extremity radiculopathy times 3 months, no previous surgery, no injuries. Beautiful. Yeah, okay. We could say, we would say that patient unable to stand straight or something like that. Yes. Good. Okay. The other thing you guys, of course, we're asking name, date of birth. We're going to ask chance of pregnancy. We're going to change them into a gown. C-spine. Yes, we need to remove glasses, jewelry. Yes, jewelry, hearing aids, dentures, if possible. It makes getting your odontoids so much easier if you can take those metal appliances out.
what if they have like permanent retainer or braces?
Did you guys notice, I didn't say this, on that AP open mouth, that patient had a permanent retainer. Did you guys catch that?
No.
I can show it to you. So yeah, they're going to remove any metal artifacts. And then for the lumbar spine, like jeans, thick waistbands, those are all going to be in the way. So verbalize this stuff for me next week. That would be terrific. Let me show you really quickly. So I'm going to go, can I close this? Are we good?
Yeah.
Okay. So I want to share, what?
Yes.
That was fine, if you had like a button, I'm sure it's something that too. I think.
Yeah, yeah. Sorry, I didn't,
No, you said down, so nothing.
I want to share my other screen. Oh, screen, that's why. Okay. Okay. Can I show you the permanent retainer really quickly and then we'll go into lab? I went too far. See it right there? Yeah. So yeah, there's nothing we can do about that. And if you're positioned correctly, it'll be above the dens anyway. But can you imagine, like, if they've got dentures or a partial hearing aids, you know, for the lateral, necklaces, earrings, all of that should come off if possible.
Cochlear implants being the exception and all that jazz, anything permanent.
Correct. Yep. With that, we're just going to note for the radiologist. Okay, sweet. Any other questions? All right. So I'm going to pause again. Okay. So, real quickly, now that we've gone through the positions in lab, there's a couple activities just to help you practice with what we've learned. First of all, I have a mini lab quiz for you. Practice lab quiz. You'll just need a scratch piece of paper, and it's the X-ray on the end here. Just identify the labeled anatomy. That's nice and simple. I have a positioning handout for you. So this I'm gonna hand out and then we'll talk about it.
Do we need the extra scrap sheet of paper or was that just like a?
I thought there was 2 people at your table. That's why I gave you 2.
No, no one wants to sit with me.
Okay. So on this handout. So here, this is to practice with what we've learned today. So look, I give you the position. You tell me the SID, 72 or 45, the tube angle, and what do you visualize? So specifically, intervertebral foramina or Z joints, and which side? So in an RAO of the L spine, what's my SID? 45, correct. Or 40 out of clinicals. What's my tube angle?
Zero.
For L spine, it's 0. We don't use a tube angle for the L spine, yeah. Good. And then what am I seeing in an oblique of the L spine, specifically a right anterior?
Right. Z.
So we're seeing Z joints, but anterior obliques are opposite. We're not
Oh.
seeing the side down, we're seeing the side up. Okay, so it's going to be left Z joints. That's the answer.
Probably on the test if it were really short answer.
Yes,
Like,
I'm fine with that. Okay, so go through and practice by filling in all of these. The key should be posted for you in Canvas. And then we've got a new case study. I have to pull it out for you, but I'll have a case study in the back. Last thing. Oh my gosh, look at the time today. Wow. Please review flexion extension spines on your own. We'll talk about them in lecture, but every year the clinical sites ask me, why don't you teach flexion extension? Why don't you check off on that? Listen, if you can do a lateral, you can do flexion and extension. We don't need to have a separate checkoff. You have enough to learn. It's all good, but please review that information. Last thing, next to the mini practice lab quiz, I have 2 interesting cases. Check those out before you leave, and then we'll draw partners. Any questions for me?
No.
Okay, so I'm going to stop my recording. Folks at home, if you have any questions, you just let me know, okay? All right. So, oh, thank you.